All right, good. Are there any questions before I move on? Yes, Mr. Johnson, go ahead. You're not in the room yet. You're still trying to join. Go ahead, Mr. Johnson. All right, I don't think it's gonna happen until you join. You have a question?
We just indicate the class.
Oh, okay. Cool.
All right.
All right. Before we move on to the next chapter, there is some principles as it relates to respiratory physiology that you need to understand. So if you're not seeing the primary stimulus for breathing and hypoxic drive stimulus to breathe, if you're not seeing that clearly, you can enlarge it on your end, right? So we need to understand the difference between the primary stimulus of breathing and the secondary stimulus of breathing. So with the primary stimulus, the primary stimulus to breathe comes from the brainstem. You learned this when we covered respiratory physiology. It comes from the brainstem. So within the brainstem, we have what is referred to as chemoreceptors, chemical receptors. And these receptors will pick up sensitive changes in the cerebrospinal fluid that surrounds the brain. Now, in a normal adult patient, when there is an increase in the level of carbon dioxide, so when there is an increase in the level of carbon dioxide, that will lead to a drop in the level of CO2. The more carbon dioxide we have building up in the body fluids, the less oxygen we will have available. As that CO2 continues to build up, eventually it will combine with water and form carbonic acid. When it forms carbonic acid, it will start to affect the pH. So the pH will now drop below 7.35. We get an acidic pH. Now, what I want you to take from the primary stimulus is that what the brain is picking up is the acidic pH. This is what it is directly picking up. It's not directly picking up the increased carbon dioxide level. It is picking up what the carbon dioxide level is doing to the pH. It's making the pH more acidic. So that's the primary stimulus. The primary stimulus to breathe comes from chemoreceptors within the brainstem, chemical receptors, protein sites that pick up sensitive changes. When there is an increase in carbon dioxide levels in the cerebrospinal fluid, the brain doesn't pick up the actual increase in the carbon dioxide. it is picking up what results from that increase, which the carbon dioxide combines with water, forms carbonic acid, and causes the pH to go below 7.35. So the pH becomes more acidotic. That is the primary stimulus to breathe. So when the body senses that the pH is too low, it will trigger increased respirations to get more oxygen into the body to balance out the pH. That is the primary stimulus to breathe. Now, if the primary stimulus to breathe is not present, for whatever reason, it could be that area of the brain is damaged, it could be the patient has been exposed to gases or fumes or toxic gases or fumes or smoke over extended period of time, over years, like somebody that has been smoking for years, working on a chemical plant. These patients, over time, the fumes that they're exposed to will damage the alveoli. When the alveoli becomes damaged or the air passage become damaged, the exchange of oxygen and carbon dioxide does not occur effectively. So with the hypoxic drive, which the receptors for the hypoxic drive, they are found in the carotid arteries and the arch of the aorta. These receptors will respond to gas exchange. So the primary stimulus respond to chemical changes. The hypoxic drive responds to gas changes. So what is happening in this patient is that because the alveoli don't work so good anymore, the air passage might be damaged from the chronic smoking or the exposure to the toxic gas. Their body does not remove CO2 completely. So their body over time starts to retain CO2, and this is chronic CO2 retention. And then this leads to chronic low O2 levels, which will ultimately lead to a chronic acidic pH. So they're going to have a pH that is chronically low. Now, what the hypoxic drive is responding to is this. It is responding to the low level of oxygen. In other words, that is the patient's stimulus to breathe. So once it's a hypoxic drive, in effect, it is stimulated by low oxygen. So in theory, because there's no evidence to support this in any case study, but in theory, it is possible that if you give this patient high flow oxygen, you can reduce their stimulus to breathe. That's somebody that relies on the hypoxic drive. When you have a patient with COPD, chronic COPD, chronic obstructive pulmonary edema, or chronic emphysema, or chronic respiratory issues, you may have to start at a low oxygen administration level for that patient, right? Because the high flow may completely shut down the hypoxic drive if that is what they have left. So ensure that you understand the difference between the primary stimulus to breathe and the secondary stimulus to breathe. So let me just recap. Primary stimulus to breathe is influenced by increased CO2, which leads to decreased O2, but the increased CO2 levels or carbon dioxide levels will combine with water and form carbonic acid, and then cause the pH of the cerebrospinal fluid to drop. The brain will sense that drop in the the pH of the cerebrospinal fluid, and it's a sudden drop. Once that is detected, the brain will initiate processes to increase the respiration to get more oxygen in. That's the primary stimulus for breathing. So what the brain is responding to in the primary stimulus is the pH, right? In the hypoxic drive, the patient has chronic retention because they have a chronic medical respiratory problem. They have been exposed to toxic fumes, or even some of these COVID patients, after they recover, they have terrible lung damage, and that can cause chronic CO2 retention. That CO2 retention will lead to chronic low O2 levels. The body is going to realize that this is a chronic state, and then it shuts off the primary stimulus. So only the hypoxic drive remains, which is the backup. The hypoxic drive, as its name suggests, responds to low oxygen levels. That is the stimulus to breathe. All right, moving along. Let's go back to PowerPoints. Chapter 10. Where is it? Chapter 10. So let's go into chapter 10. So we just look at the initial stage of the airway assessment. We reviewed the anatomy and physiology. At the upper and lower airway, we looked at the problems and the maneuvers for fixing that. Maneuvers for fixing the problems and the equipment that we can use to assist us. Now let's focus more on respiration and artificial ventilation. Right, so topics that will be covered: the physiology and pathophysiology of the respiratory system, respiration, positive pressure ventilation, oxygen therapy, special consideration, and assisting with advanced airway devices. So let's look at the physiology and pathophysiology. Mechanics of breathing. So ventilation, and we know this. Ventilation is the process of moving air into and out of the lungs. So there is a passive phase and there is a active phase. We learned this last week. Active means muscle is required. Muscle use is necessary. Passive means no muscle contraction is needed. And the two phases of ventilation are inhalation and exhalation. Now, this is a question. I don't know if anybody can answer it, but if you can, go right ahead. Out of the two phases of ventilation, which phase would be negative pressure? Which phase would be positive pressure? Critical thinking question. Yes, Mr. Johnson.
All right. Would I say the inhalation would that be the positive pressure?
Which one?
Inhalation.
Why?
Because you don't put pressure upon the lungs for it to expand.
By inhalation?
Yeah.
No, I would have to disagree. Think about it again. So, mute the mic. Mute your mic. All right, so remember that, let me see if I can draw it here. remember that the diaphragm is like this. So the diaphragm is like this when it's relaxed, right? And then the rib cage is on top of it, right? That's what the diaphragm is like when it's relaxed. So when it is contracting, the diaphragm moves down like that. So it moves down, and this is the rib cage, right? This is the, come on, man. Let me move this out of the way. Again, get this out of the way. Get this out of the way. Let's do this again. Right, so the diaphragm, when it's relaxed, is going to be like that. Tends to flatten. Then you have the rib cage like that. Right, so have an arrow going that way, have an arrow going that way. And over here, arrow is going this way. Over here, arrow going that way. All right, let's draw a line between them. Now, when a patient inhales, just think about it practically, right? When a patient inhales, would you want the rib cage to move in or out? Who want to answer that? When a patient is inhaling, which direction we want the rib cage to move? Inward or out? Yes, Mr. Wilson.
Thoughts.
Outward, right. No. If, let me write it out. So this would be exhalation. Okay, let's see when I type it. Exhalation. Let's see if I can enlarge that. So this would be, just bear with me. That's exhalation. And this would, over this side, would be inhalation. Let me enlarge that. Move this down, enlarge. Right, so you have inhalation, exhalation. Let me go back to the pencil. And here, the arrows move in. Okay. All right, good. So when we inhale, we want the chest wall to move outward. That is pretty straightforward. Now, what you need to understand, and this is very important, so make sure you remember this concept, right? Very important concept. Where can I put it? Put it here. We have V, E, and then this arrow goes this side. All right, so remember this concept. Volume and pressure works inversely. So volume and pressure works inversely. What does that mean? It means that volume has to do with space, right? So if there is an increase in space in an area, the pressure inside of that area is going to fall. So if volume increase, pressure decrease. If volume decrease, so if the size of an area decrease, the pressure inside of that area will increase, right? Now, if when a patient inhales, the intercostal muscles and the diaphragm contract, and when the diaphragm contract, it moves down, and the intercostal muscles pull the rib cage up and out, as you can see on this side. So you see the rib cage moving out, diaphragm flatten. What is happening to the space inside of the intrathoracic cavity? What is going to happen to that space? What is going to happen to the pressure in that space? Who want to answer that question? It's Mr. Powell.
The space increases, causing negative pressure.
Right. So there's going to be an increase in the intrathoracic space, which creates a negative pressure, right? And air will always move from where there is a high concentration to low concentration. So you will pull air into the lungs via negative pressure. So when we breathe in, negative pressure is created. So on this side where we have exhalation, when the diaphragm relaxes, it moves back into a dome shape. When the intercostal muscles relax, the rib cage come back in and down. What is happening to the intrathoracic space? What is happening to the pressure, the intrathoracic pressure? Who wants to answer that question? Yes, Mr. Johnson.
The pressure would have decreased because the volume of air would have gone down back in the exhalation process.
No. Come again. The volume is the space that is decreasing. If volume decrease, what happens to pressure? They work inversely.
So the pressure would have increased then if the space.
Right. So if the size of the chest decrease, look at the direction of the arrow. That's pressure moving out. There's an increase in pressure. So you push the air out of the lung. That's positive pressure.
Oh.
You get that?
Force it out. Force it out.
Right. So we push air out of the lungs when we exhale. And we pull air into the lungs when we inhale. Got it?
Okay. Because the thing when me look upon still are the movement of the diaphragm. That's why I said that the first time.
The diaphragm is moving up when it's relaxed. It moves up.
Right.
Contract, it moves down. So everything that is happening when, hold on, mute your mic, getting some feedback. Everything that is happening when the diaphragm, so when the diaphragm moves up when it's relaxed and the rib cage moves in, it is decreasing the intrathoracic space. So the volume in this space has decreased. So it's going to cause an increase in pressure. And that pressure will push the air out of the lungs. So in the normal physiology of breathing, we breathe in with negative pressure, we breathe out with positive pressure. And remember, volume and pressure works inversely. If volume increase, pressure decrease. If volume decrease, pressure increase, working opposite. All right. Now, inhalation is the active process. Muscles expand, the size of the chest increases, and then we get a negative pressure, or the pressure decrease, and that pulls air into the lungs. In the exhalation phase, which is a passive process, muscles relax, the size of the chest decreases, and a positive pressure is created. So we push the air out. That's the normal physiology of breathing. However, when we have to breathe for a patient, so when you have to create ventilations for a patient, you will be using positive pressure. And that's why when we breathe for patients, we have to breathe for the patient at a slower rate than the normal breathing rate. Now, tidal volume, the amount of air moved in one breath. We all know that by now. We are bright people. Minute volume, the amount of air moved in and out of the lungs per minute. Dead space, air moved in ventilation, reaching the alveoli. So anywhere within the respiratory tract that the exchange of oxygen and carbon dioxide cannot occur is dead space. And it's constant, 150 mils. Alveolar ventilation is air that actually reaches the alveoli. So when we inhale, not all the air will end up in the alveoli, right? And the average tidal volume for an adult is what? 500 to 700 mils, right? So if you subtract the dead space from 500 mils, you'll get the actual alveolar ventilation. Diffusion is the movement of gas from high concentration to low concentration. Yes, Mr. Johnson.
Yes, sir. You have a calculation thing for the dead space
The what?
tidal volume.
Dead space is
Calculation.
constant, 150 mils.
Oh, okay.
The tidal volume for an adult is 5 to 7 cc's per kilogram.
Okay. All right.
Yeah. Yes, Mr. Wilson.
Sir, let's say ensure some loss. Right, so the negative pressure when you pull air into the lungs, so that'll be inhalation.
Yes.
And the positive pressure when exhale, so it'll push out.
Right.
Right, just make a look at it. All right. So
But when you breathe for the patient, you are providing what type of pressure?
positive.
Positive pressure. Yes.
All right.
Good. Right, now, external respiration, diffusion of oxygen and carbon dioxide, exchange of gases between the alveoli and the circulating blood. Now, external respiration is also known as pulmonary respiration. You have internal respiration, which is the exchange of gases between the blood and the cells. And that is also known as cellular respiration. Cellular respiration, oxygen from blood diffuse into the cell, carbon dioxide diffuse from cell into the blood. All right, now pathophysiology of the cardiopulmonary system, mechanics of breathing, disrupted, gas exchange interrupted, circulation issues will follow. So what this is simply saying is, if there is a problem with ventilation, if there's a problem with oxygenation, if there's a problem with respiration, it will lead to circulation problems because it's both of these systems work very closely together. All right, respiration. Adequate and inadequate breathing. So we're getting close to that. So the brain and the body cells need a steady supply of oxygen. If the oxygen level is depleted in the body and less oxygen is available to the cell, hypoxia develops. Hypoxia means low oxygen. If less oxygen is available, it means more carbon dioxide is present, and this will lead to hypercarbia or hypercapnia, which is high carbon dioxide levels. Assess how well cardiopulmonary system is accomplishing oxygenation and carbon dioxide removal. So you can't assess one system without assessing the other. You're going to assess the respiratory system, you need to look at the circulatory system. Adequate and inadequate breathing. Compensation for hypoxia or hypercapnia is predictable. We talked about this earlier, right? So the respiratory rate and depth is going to increase. The heart rate is going to increase. Patient is going to start to show signs of dyspnea or shortness of breath. Early on steps of adjustment can meet the needs of the body despite respiratory challenges. So in the early stage, they tend to compensate fairly well. But it's not adjusted. Respiratory distress can move from mild to moderate to severe. So respiratory distress, body compensating for a respiratory challenge and meeting metabolic needs. That's what respiratory distress is. Now, inadequate breathing. Now, some books have inadequate breathing as a broad heading, and then there are some books that classify inadequate breathing as poor ventilation, because if you're doing national registry, they see inadequate breathing in a question, it means that that patient is not ventilating properly, right? However, your patient moves from respiratory distress to respiratory failure and then respiratory arrest, right? And this is where it gets tricky, especially with respiratory distress. The respiratory distress is the most tricky one because with respiratory distress, your patient moves from mild to moderate to severe. Now, mild and moderate respiratory distress would mean that your patient's level of consciousness has not been affected, right? The respiratory rate is going up. You might see a little muscle use, but it's not severe. And your patient has good chest rise bilaterally. So again, respiratory distress means respiratory distress in the mild or moderate stages. The brain is still getting adequate oxygenation, right? So the patient will be responsive. However, they will be showing distress. You might see the breathing rate going up. They might be working a little hard to breathe. However, you can still observe visible chest rise. So that's mild or moderate. Now, once a patient is in mild or moderate respiratory distress, the treatment is going to be supplemental oxygen. You're going to use a supplemental oxygen device, and that can either be high flow oxygen or low flow oxygen. So that's the first phase of respiratory distress, mild, moderate. Now, when we start to get to severe is tricky, right? So think of severe respiratory distress as if the patient is on the verge. So the patient is on the verge of failing. That's how you're going to think about it. So what you're going to note with your patient at this point is that the level of consciousness start to change. The patient might start to get sleepy. The patient is not communicating with you properly, right? their breathing pattern starts to become severely labored. So they start to work very hard to breathe. But when you look at their breathing rate, you note that the breathing rate is either coming down or you catch it at a normal level. Right? So that is a red flag. If somebody is working extremely hard to breathe and showing signs of altered mental status with a normal breathing rate, that's not a good sign, because if the compensation was good, they would be responsive. It means that that patient is now coming down. So when you catch the breathing rate at a normal rate, it's actually coming down, not going up. So the patient is on the verge of failing. However, at this point, the patient still presents with visible chest rise on both sides of the chest. So you can still see visible chest rise in this patient. So this would be a patient that is going into respiratory distress, the severe phase of respiratory distress. Now, for the textbook question, if this is the type of presentation you see in your textbook, the treatment is to breathe for the patient. You're going to be prepared to breathe for the patient, or in EMS we call it bagging the patient. In real life, this patient is about to fail on you. You will still have the patient on high flow. While the patient is on high flow supplemental oxygen, you will prepare your BVM to bag the patient. So you will be prepared to breathe for the patient in the field. We're not going to just do it right away. You have to prepare and then bag the patient. So we're going to prepare, watch the patient. We'll realize that the patient can no longer do it effectively on their own, and we take over at that point. But if you see a question that suggests that your patient, this is for your exam purposes on the platform, suggests that your patient is in severe respiratory distress, then you need to bag the patient. That's the answer. You're going to have to breathe for the patient. No, that is a mouthful. This might be the most important slide in this PowerPoint. If you can differentiate mild, moderate, and respiratory distress, you go. No, I've said a lot. Is it clear so far? Raise your hand if you understand what I've said thus far. Have a question, Mr. Olson?
Yes, sir. So for the patient over there, I got you. So mild, you're saying them on the verge. If you treat it as if them on the verge of failing.
No. If something is mild, why would you want to treat it if it's on the verge of failing? Mild is not bad. Severe would be bad.
So severe would be
Right.
but so in the case of the mild, you just watch it to see if it'll go severe.
You're still going to treat it. So you still will treat mild, but it's supplemental treatment, and the patient might not move to any other stages. So if the treatment is adequate, the patient will improve from mild to better.
So if me have a bit practical then, so me present with a patient and I'm gonna show mild symptoms of respiratory distress.
Yes.
So the treatment then would that be, so me give him supplemental oxygen then.
Yes.
Still take note of the level of consciousness.
That's a must.
And just keep on reassess to see if it'll move from mild going further to severe or possible failure.
Right. So you treat the presentation, you monitor the patient. Is your intervention working? Is it not working? Is the patient getting better? Is the patient getting worse? Yes.
So what? All right. So sir, what definitely may I look for more than one factor. May I look for here? What would I say? At the level of consciousness, may I look for what I point say yes, it will go severe, or may I look for more than one thing?
You can't look at the level of consciousness alone. So you have to look at the patient's level of consciousness and their effort in breathing.
Effort.
Right? So you look at their level of consciousness, and then you will consider the rate that the patient is breathing, whether it's regular, whether you can see visible chest rise bilaterally. Is the patient using muscles? What is the sound of the breathing? What is the pulse ox? All of these things would be considered.
Okay, sir.
It's a thorough assessment. So
So
we can't make decisions on a PISA assessment, right?
so,
It has to be thorough.
so sir, the main thing is once you treat, just reassess
Always,
thoroughly reassess the patient.
right? So once it's a critical patient, you reassess every 5 minutes. That's standard.
Okay.
All right. So that would be respiratory distress. Remember the phases. You have mild, moderate, severe. Mild and moderate, your patient is still able to compensate okay and provide the brain with adequate perfusion, but they still require supplemental O2. With severe respiratory distress, the patient's level of consciousness starts to change, breathing rate can still be going up, or you might catch it coming down, but the patient will be working extremely hard to breathe. When the patient get to this stage, you need to prepare to bag your patient. So you're going to treat the patient as if they have failed, if the respiratory system has failed. So that's respiratory distress. Now, if respiratory distress is not corrected, it will lead to respiratory failure. So, and this is where we start to get into the inadequate phase of breathing now. So, occurs when challenge are too great for our body's compensation mechanism, also known as respiratory failure. Exceptionally important to recognize, often lead to respiratory arrest. Now, with respiratory failure, you're looking at two things, just like before, two things, right? Fairly quickly. What is your patient's level of consciousness? That's one. So you need to look at the patient's level of consciousness, and then you will evaluate the patient's breathing, right? Specifically, their ventilation status. Now, once you have a patient with a decreased level of consciousness and poor chest rise, so decreased level of consciousness, poor chest rise, right? And poor chest rise can be from slow breathing, it can be from slow breathing, shallow breathing, irregular breathing, it can be from paradoxical breathing, where the both sides of the chest are moving in opposite directions. So once there is a ventilation problem with altered level of consciousness, you have a patient that's failing, right? So this is where your patient is failing. And this is where our management now becomes positive pressure ventilation, definitely positive pressure ventilation, but you will also see the term RT. Oh, you will also see the term assisted ventilation. So it's positive pressure ventilation because we are breathing for the patient. It is referred to as assisted assisted ventilation because the patient still have some amount of movement at the chest. Right? So even though it's poor chest rise, the patient's chest is still moving. So we are going to assist the patient's ventilation. Right? So that's respiratory failure. Again, respiratory failure, two things must be considered fairly quickly. What is the patient's level of consciousness? Can I see visible chest rise or adequate chest rise bilaterally? If the patient's level of consciousness is altered with poor chest rise bilaterally, this is a patient in respiratory failure. The patient requires positive pressure ventilation or assisted ventilation with O2. So you're going to use your oxygen source once it's available. So that's respiratory failure. Respiratory arrest is straightforward. Arrest means stop. That's what the word arrest means. It means to stop. So respiratory arrest means the patient's respiratory system stop. It now work. Stop working. There is no movement of the chest. There is absolutely no movement of the chest at this point. You might see, let me not say absolutely no, you might see agonal gasp. But if we see agonal gasp at this stage, we don't treat it as breathing. So we treat it as if the patient have no breathing. Now, when there is no chest rise, you definitely need to ensure that your patient is not pulseless. Right? So if there is no chest rise bilaterally, does this patient have a pulse? Yes. If they have a pulse, then you need to manage the issue with the airway. If they don't have a pulse, then you need to manage two things. You need to manage airway and the circulatory system. So with respiratory arrest, the treatment for arrest is going to be artificial ventilation. Artificial ventilation or positive pressure ventilation. It's still providing positive pressure, but it's artificial. It's classified as artificial ventilation because you are now creating the ventilations for the patient. You're no longer assisting, you're creating the ventilation. And once you have an oxygen source available, you will attach it. And that's the three phases: respiratory arrest, respiratory failure, respiratory arrest. Right? Respiratory distress, respiratory failure, and respiratory arrest. Very important. All right, respiratory distress, cancel that writing. All right, so the patient assessment is signs of adequate breathing. You're looking for normal mental status, normal pulse oximetry reading, relatively normal skin color. Right? And when we assess breathing, we're looking at rate, rhythm, quality, depth. Signs of inadequate breathing: chest movements are absent, minimal, or uneven. Abdominal breathing, no air can be felt or heard at the nose or mouth. Breath sounds are diminished or absent. Wheezing, crowing, stridor, gurgling, or gasping during breathing. The rate of breathing is too rapid or too slow. Breathing is very shallow, very deep, or appears labored. Cyanosis is present. Inspiration and expirations are prolonged. Retractions and nasal flaring in children. Low oxygen saturation reading less than 95%. Hypoxia, major causes. A patient is trapped in a fire. Patient has emphysema. Patient overdose on a drug that has a depressing effect on the respiratory system. A patient has a heart attack. All of these situations can lead to hypoxia. Patient care. Inadequate breathing, you will provide either artificial ventilation or assisted ventilation. And the difference I already mentioned before. Artificial is for the patient in respiratory arrest. That's the classification. For assisted, it is a patient that still has some movement of the chest, but it's not sufficient to perfuse the brain. To the non-breathing patient and the patient with inadequate breathing, right? Provide supplemental oxygen to the breathing patient. So that's the one in mild or moderate respiratory distress. When do I intervene? Often respiratory failure patients will be breathing and conscious, right? So that's when they're moving from the severe to failure. You can catch them at that point. Identify adequacy of breathing. And for breathing to be adequate, their mental status should not be decreasing, it should be improving. And that is what is going to guide your intervention, the patient's level of consciousness and whether or not they have adequate ventilation. Think about it. What signs might identify the need to intervene in a breathing patient? If you have a patient that's breathing, what are you looking for that is going to tell you that you need to do something about this? That's a question. Go for it. Who want to take that one? Who is that? I didn't say. Oh, go ahead, Mr. Wilson.
Well, sir, first thing what I look at the level of consciousness, also if proper ventilation is taking place.
Level of consciousness and what?
And ventilation.
That's all you have to look at? All right, go and think about that. Mr. Johnson, go ahead.
Yes, sir. I look for the bilateral movement of the chest.
Okay, just the chest rise bilaterally. What else?
Not here. You're going down low.
What else? What else? Sorry.
Because you want to see the person have adequate ventilation take place.
Okay, so that's all. Anybody else? Remember, it's not only inadequate ventilation we treat, we also treat difficulty breathing. So you can only focus on looking for inadequate ventilation. You have to look for difficulty breathing as well.
Hello? Sir.
Yes.
Right. So as you say, not really say inadequate because you say we have to monitor the patient, so we catch them if them are sleeping the arrest.
Right.
So they have the bug thing they feel put the positive pressure if needs be.
Yes. All right. Anybody else? Miss Wellington, Miss Cephas, Miss Lewis, George. Where are you people?
Sir?
Go ahead. I am listening.
What I was thinking about is, of course, we're going to observe the normal, the rise and fall of the chest to see if it is normal. Also, I was thinking about even to identify if the airway was actually being obstructed, because we're looking at a patient that is actually breathing. We want to identify if it is normal breathing.
Mhm.
And yeah, we want to identify if it is normal breathing. So whether it is mild, moderate, or severe.
Okay, I hear you. Miss C first. Miss Wellington. Go ahead, Miss C first. Go ahead.
Sir, maybe their body positions,
Yes, you can look at the body,
color,
the position of the patient,
the color of their skin, even
skin
though that
color.
would be a circulatory, but you said they're linked, right? So skin
Yes.
color and in children, nose flaring.
Mm-hmm. All right.
Okay.
Miss Wellington.
Sir, I would check the patient level of consciousness.
LOC is important. Yes.
And also another thing to also, sir, you could probably check the person pulse rate.
Um, it's going to be something that must be done. I want you to focus more on the breathing assessment.
Okay, sir. So I would check the person level of consciousness. And if the person is able to respond or is unresponsive, and then I would know how to proceed from there.
Okay. Mr. Chantiloop, you have something to add?
Yes, sir. I
Go
was
ahead.
looking at probably the position that the person in might need some assistance to assist with the breathing.
Yeah, man, that's something that should be considered. So that would be correct as well. All right. All right. So we're getting the general idea. All right. Now, positive pressure ventilation. Positive pressure ventilation. Forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. Uses force exactly opposite of how the body normally draws air into the lungs, which we learned previously. When we're breathing normally, we're breathing with negative pressure. When you breathe for the patient, you're ventilating using positive pressure. The negative side effects of positive pressure ventilation. So because it goes against the normal physiology of breathing, it can't be too fast, it can't be too forceful, right? So if it's too fast, too forceful, or the head is not positioned correctly, if you breathe too fast or too forcefully, especially too forcefully and too fast, you can get air bypassing the air passage and going down the esophagus to the stomach, and then the stomach starts to get distended, and you are going to feel the difference. So once that stomach starts to move upward on the diaphragm, it's going to become very difficult, very difficult. You're going to start to have challenges to squeeze the BVM or to ventilate for the patient. All right. So the other thing that can occur is if you're ventilating too fast or too forcefully, it can reduce the amount of blood that is returning to the right side of the heart. So it can decrease venous return, right? And one of the ways you can check that out, if you have a lot of hands on deck, if somebody's bagging the patient, when you feel the carotid pulse, each time the patient is bagged, if the carotid pulse disappears, the person is ventilating too forcefully. and too fast. Right? So that's reducing the venous return. Do not ventilate patient who is vomiting or has vomitus in the airway. That's a no-no. You can't breathe through vomit. Miss Lewis, mic is on. You have a question? Okay. So you can't breathe through vomit. It's just not possible, right? And if the airway is not positioned properly, you're gonna get vomit. You're gonna get air into the stomach, and always assume that a unresponsive patient has a full stomach. Yes, Miss Cephas.
Sure. So if the patient is vomiting and the airway is blocked as well, would you still suction?
You
How would
have
you
to
know
suction.
that?
You have to suction. And if it's too chunky to suction, you clear it with your fingers.
All right. Thank you.
Right? So the thing is this: when you're doing airway management, if it's not being done properly, the airway is gonna become very messy. You're gonna get stuff coming up in the airway. You're gonna have problems managing the patient's airway. The very first cardiac arrest patient or call I had when I was working with the ambulance.
So you want to talk about fitting, I'm not talking about fitting. It's a pussy that relate to your class.
When you realize turn the mic on, you realize turn the mic on, it's a Johnson. May I wait for it for mute? And that recorded, So that outburst in the class was recorded. All right. Come on, people. The need to do better than that. Now, professionals act as professionals. That I have to make a report on that. So it is what it is. Right? We are who we are when nobody is watching. You're a professional, be a professional all the time. See, me not even remember what me did I talk about. What was I talking about previously?
Sorry, that's the first cardiac arrest case. So yeah.
Right. So yes, the very first cardiac arrest call I went on while working on the ambulance in Jamaica. We got a call, middle-aged female found unresponsive by her husband, right? We responded to the location. We had some issues finding the location. It probably took us, I would say, 10 to 15 minutes. Took us to find the location. When we got there, the husband was trying to resuscitate his wife, but it wasn't being done correctly. You could see that he was definitely in panic mode. He was trying to resuscitate her based on something he had saw or learned, but it just wasn't being done properly. When I got there, the patient abdomen was distended. The patient had a distended abdomen and she wasn't obese. There was vomitus coming up through the patient mouth, and it was thick vomitus. And the husband was trying to breathe for his wife through that. So he might try to breathe through the vomit. At that point, I knew that there's no way she would have survived, right? I knew in my head patient wouldn't survive. So my question to you, based on the description of the scene, would it make sense for me to go assess the patient's level of consciousness, do a head tilt chin lift, look, listen, and feel, put in an airway adjunct and breathe for this patient would be the most relevant action at this point. Yes, Ms. Cephas.
First, you'd want to get rid of the vomit, or at least try to reduce it. So,
Okay. What would you do?
Well, you said it was thick, so I'd use my fingers.
You're not thinking, Ms. Cephas, you're not thinking sequential. So when you're gonna answer me,
Okay, so
what would be the first thing that you do? You need to think sequential.
I would put her on her side.
And what?
Side. Then I would try to remove the vomit with my fingers.
All right, so stop there. Now, there are two problems. It's not one. There are two significant problems that needs to be addressed. The vomitus that's coming out of the mouth and the distended abdomen. If you don't fix the distended abdomen and clear the vomitus out of the mouth, you're gonna have the same problem that the husband is now having. So you're going to have to turn this patient on their side and put, one of you will have to put pressure on the abdomen. So you're gonna have to put some pressure on that abdomen, and as the chunks come up, you remove them, or as the vomit come up, you suction. That's what I had to do, right? And then I initiated airway management. Now that is time consuming, right? To be clearing a gastric distension and the airway is time consuming. When I needed to initiate basic airway procedures, right? Now the outcome is the patient didn't survive. The patient did not make it, right? So airway management is essential, and there are several factors that were at play with that particular call. One, Jamaica does not have a dispatch system. So if you call 119, you're not going to get a dispatcher that is trained that can give you instructions in terms of what you need to do. That would have made a difference. The husband was not properly trained in CPR, right? He had never done a CPR course. Now, if you have a family member that has chronic illnesses or conditions that are related to their heart, it is very wise for you to learn some form of CPR course for lay persons, right? Very important that you know to do CPR. If need arise, that was also a factor. The other factor was because the airway wasn't properly positioned and the CPR wasn't being done properly, specifically the airway positioning, that contributed to air building up in the stomach. Stomach was full, all of that started to come up back in the air passage, and the patient aspirated. Right? So airway management is very important. Very important. And whoever has that task, if you are responsible for airway, especially if you're providing positive pressure ventilation for your patient, you need to pay attention to what you are doing, right? Because every time you squeeze that back, you need to see the chest rise. If you do not see the chest rise after you squeeze that back, the air went somewhere. So the air went somewhere if you did not see a chest rise. And it's going to take the path of least resistance, right? So you have to pay, you can't be bugging the patient and you look to your left and look to your right. You need to focus on the patient's chest. Am I getting chest rise? Is it adequate? is it at the appropriate rate? Right? That's going to be important. Yes, Miss.
Sir.
Use somebody else's mic. Use somebody else's mic. Use somebody that you're close to.
Hear me now, sir?
Yes, much better.
All right. So when you squeeze in the airbag, you also have to focus on the mask of it. It is seated on the person's facial area also.
That would be correct. Yes, Miss Wellington.
Sir, if it was a case where that lady that died, if it was a case where her had some knowledge
Not
or
hearing
some
you. Not hearing you. I can't hear her. Type what it is that you're asking in the chat, Miss Wellington. I can't hear you. What is the time? 11:45. Let me. Yes, money.
Yes, sir. Just a small question. So in regards to that scenario, right, that happened to you, you would say it's basically the aspiration that actually took the life of that person because of the whole vomiting and all of that.
I can't say that is the definitive cause of death. I don't know if the patient had a heart attack and whether or not it was a massive heart attack. Because if the wife had a massive heart attack, even if she got the best CPR in the world, she wouldn't survive. You can't flag a dead horse, right? But I do know that the poor airway management was a factor. So I know for sure that was a factor, right? But I didn't have the knowledge I have now then, and I didn't have the equipment that I would need as a advance, right? So I wouldn't be able to see if she had a heart attack. Couldn't do a 12 lead ECG on her and stuff like that. So I don't know, but I do know for sure that the poor airway management was a factor. That's how she got air in the stomach. But I don't know what led to her becoming unresponsive and going into cardiac arrest.
Okay.
Mr. Johnson. Yes.
Yeah, I get problem, you know. Yeah, in regard to a little business over here, it don't really have nothing really for do with it, sir. They make you know straight up, big bad.
We know say now
So
nothing to do with
the man
me, but
just cut me through the coil. Me I tell you, say no. Everything I saw mess up. People are running out of the lecture room over there. It's like everything I come down for in the morning. You know. Them have a dental course we are going to run. Just come in, me have to bad up. The soldier carry the man them come. So, you know, nothing for this. So, my apologies for the outburst in class. No, for now. So,
I know it
apologies for who here tonight, class. Me not hear you think I chip out.
I'm saying I know it doesn't have anything
Yes.
to do with me, but you have to be aware of what you're saying in the environment because it's being recorded.
Right, sir. So, me make sure me open the apology so everybody can hear me.
All right, boss. No problem. No
Yes,
problem.
sir. Big man thing. All right. Good, sir.
All right. Interesting day. All right. So yes, we're go break. will take a break. We will start back at, let me see, 1 o'clock. We will resume. So we will break here.